Thank you very much. So it's always about this vulnerable plaque, which I think it acts like a ticking bomb. We don't know when does it strike, um, when does it explode. Um, and I think the core of this presentation is about how to diagnose a vulnerable plaque. Do we have the efficiency of having a good imaging of this vulnerable plaque? Can we predict that this plaque is vulnerable? And then if we predict that this plaque is vulnerable, can we treat? And do we have evidence that treating such vulnerable plaques will be effective in preventing cardiovascular events? I think these are the two questions: how to diagnose and how to treat a vulnerable plaque. And as you can see from these specimens, the well-known criteria of a vulnerable plaque is the one on your left-hand side. This is a plaque with heavy lipid core and with a thin fibrous cap that's liable for rupture. These are the complications that can occur in such a vulnerable plaque, a high risky plaque. It can go into intraplaque hemorrhage. It can go into plaque fissure, plaque rupture, plaque erosion, and now they consider the calcified nodule as one of the vulnerable plaques. So all these complications can occur if we can diagnose this plaque and if we can confirm that this is a high vulnerable plaque. So these are the tools, if you wish, that we can use to diagnose a patient with vulnerable plaque. Of course, this is a non-invasive tool, which I think all of us would prefer to have a non-invasive tool to diagnose such criteria of being vulnerable. And by the CT, we can diagnose an eccentric pattern, outward remodeling, low attenuation plaque, and spotty calcification, and the most important is the napkin ring sign. But all other tools that we can use are invasive in a sort. And I think that we will have later in this session a debate about which is more accurate, if you wish, the non-invasive versus the invasive tools, the IVUS, the virtual histology IVUS, the OCT, and the near-infrared spectroscopy. All of them have specific criteria to diagnose whether the patient is having such vulnerable criteria, which puts him at high risk of developing acute coronary events, even if the plaque is non-obstructive, even if the plaque is causing no flow-limiting criteria. And this is very important. We are talking about a plaque that looks benign with no symptoms now, but it might explode within few months or a couple of years. So what evidence do we have that such criteria is enough to diagnose a vulnerable plaque? We have tens of studies that made this investigations, but I think I will quote two important trials. One of them is the Prospect trial and the other is the CLIMA trial. The Prospect trial used the IVUS and the near-infrared spectroscopy, and they used these criteria like the large plaque burden, the thin cap fibroatheroma, and the lipid-rich core, and they proved that patients with such criteria compared to patients without such criteria have worse prognosis in the terms of future acute coronary syndrome and the MACE following the patients over 4 to 5 years. So this was the first trial. The second trial is the CLIMA. It's a more recent trial, and they use the OCT. Again, the OCT has definite criteria, being a small lumen, a thin fibrous cap, a large lipid arc, and the evidence of, or the presence of macrophages as a sign of inflammation. So again, they proved that such criteria are very much predictive of cardiac events within the next 12 months. So now we have firm evidence that by using such criteria, at least in invasive modalities, if we follow the patients, we can prove that such criteria can diagnose a patient with high-risk vulnerable plaques. And again, from the prospect trial, the higher the number of criteria, the higher the incidence of major adverse cardiovascular events. So two criteria is more risky than one criteria. 3, 4 criteria is carrying the highest risk, again, according to the prospect trial. And this is a very interesting trial. Again, they compared post-STEMI and post-non-STEMI patients, whether you have high-risk criteria, solid lines, or no high-risk criteria, dotted lines. And as you can see here, the patients with solid lines, with high-risk criteria, have much more MACE events in non-culprit lesions. So we are talking about post-STEMI patients with evidence of vulnerable plaques in other non-culprit lesions. Again, we can prove that these patients are at higher risk for future events than patients without these criteria. This is very important for imaging. And this is the CLIMA trial. As you can see, very beautiful evidence from the OCT. The first one is having no evidence of vulnerable criteria. And on follow-up after 1 year, the patient has the same stable plaque. But look at the other patient is having this thin cap and the high lipid core. And as you can see, after 1 year, this patient developed more involvement of the plaque, whether due to plaque hemorrhage or thrombus formation or whatever is the complications. But you can see on the coronary angio, it became more severe. So again, using invasive imaging will predict the prognosis of the patient, as you can see on the right-hand side. And again, with increasing the number of criteria, the prognosis is becoming more worse. But now we are talking about another concept, which is not only the coronary plaque criteria is important, but again, the patient himself, there are other criteria like the viscosity of the blood, like the thrombogenicity of the blood, like the psychic stress. All of them, when combined together, will increase the possibility of being unstable or vulnerable. So we are now talking about the concept of a vulnerable patient rather than a vulnerable plaque. And this now take us to the possibility of treating a patient as a whole and not only treating the vulnerable plaque. And that's why you can see the literature, 2 types of treatment. The first is the medical treatment for treating the patient as a whole. And unfortunately, we are limited with the tools that we are using, but most of these trials use the PCSK9 inhibitors. And by this, they can see, they can show mostly that the blue bars having better prognosis. Those are patients that received the PCSK9 inhibitors. So this is a good tool to stabilize vulnerable patients, if you wish. But now the most interesting, the most exciting is how to treat the vulnerable plaque itself, focal management of the vulnerable plaque. And I'm talking about 2 important trials. One of them is the Prospect Absorb. They are using the bioabsorbable stent at that time. And they have evidence that this might improve the prognosis of the patient. But the most recent one is the Prevent trial. And again, as you can see, putting a stent in the blue bar reduce the all-cause death, the myocardial infarction, and any revascularization according to this trial. And this is in contrast, the Prevent trial, which I'm talking about, a trial that was published 2024, so just a couple of years ago. This was the first trial to prove what we call the preventive PCI, putting a stent, a drug-eluting stent, of course. Can I have 2 minutes, please? لا دقيقتين. شكرا دكتور. So the PREVENT trial is the first to apply this preventive concept. This is a new concept in order that we, when we diagnose, of course this is important to diagnose the vulnerable plaque, and then we put a stent, a drug-eluting stent, we can reduce cardiac events by this preventive sort of preventive trial. And this is to compare with the negative results of the PCI in stable patients. If we put a PCI in stable patient according to the COURAGE trial and the ischemia trial, it was not better than medical treatment. But for the PREVENT trial, this was better than medical treatment. So perhaps we are now much more clever in choosing which patient will get benefit from PCI by this, by applying this vulnerable concept. And this is the summary of the PREVENT trial. Again, preventive PCI versus medical treatment alone, 4 years follow-up, and you can see significant reduction in MACE and even in mortality. And this was published in Lancet, and it was a very impressive. And the future carries, again, 4 major trials, again, studying these concepts of the vulnerable plaque, whether to do PCI for such patients or not, and we are waiting for these results. So my summary is that vulnerable plaques are prone to thrombosis owing to their specific structure and biological chemical features, and now we think that we are clever in identifying these features of vulnerability. Whether the non-invasive or the invasive diagnostic modalities are much better, this is a debatable issue still. Pharmacological treatment for vulnerable patients and interventional treatments is still under study, and we are waiting for future large-scale randomized controlled trials. Thank you very much for your attention.